Good morning, everybody. This morning, we are privileged to have Dr. Warren Lowman. He is a clinical pathologist in clinical microbiology and infection prevention and control at Pathcare Vermaak Pathologists and Wits Donald Gordon Medical Center. He's also an honorary lecturer at the Department of Clinical Microbiology and Infectious Diseases at Wits University, or Wits School of Pathology. Thank you so much for coming to present to us. We're honored to have you.
My pleasure. Thank you for inviting me. Okay, so today we're going to talk about antimicrobial therapeutic drug monitoring, and it's beyond the conventional antimicrobial therapeutic drug monitoring. That's why I entitled it Beyond the Trough. We're not talking about vancomycin and amino glycosides today. Those are old news and boring, although they're not done very well themselves in any event. So, it is worthy of a separate discussion, but I'm really going to focus primarily on beta-lactam TDM and look at what is the clinical value, the very important aspect of its impact on resistance, and why we should be motivating for the case for precision dosing. I'll share some stats with you there, but those will come up again. So if you look at a metric, and this is sort of how I frame TDM at the moment, about the knowns and unknowns in this rubric, this is kind of where we sit with antimicrobial therapeutic drug monitoring, especially of the drugs that I'm going to discuss today. And largely, it's even the worst case scenario is the unknown. It's actually things we are neither aware of nor understand. There's many aspects to TDM that we do not understand fully. And I think that has largely to do with the highly variable pharmacokinetics of individual patients. So, and this is kind of where TDM lends itself, because it actually gives us a measure now of knowing exactly where you are rather than guessing. So I'm by no means an expert pharmacologist. I am a clinical microbiologist, but I have quite an intense interest in this field. And we've now been doing TDM for 3+ years. We do it using the gold standard of LC-MS. So that's liquid chromatography mass spec. It's a highly accurate chemical analysis method. And I've yet to see results that cause me any question. Usually if a result is in a question, it's because it's related to pre-analytical factors. Was the dose given? How much was given? Was it still running in? Sometimes levels are taken and the drug is still busy being fused, for example. Those are the kind of things. The actual value that you see is the value that you get. And really what I want to share a little bit today is about that 3+ years of experience that I have in this field, and also just to highlight the developments in the literature. So the way I'm going to present this, we're going to look first at the actual clinical problem. Why do we need TDM? I'm just going to highlight 3 key studies that I've just chosen randomly. There are many, but these are recent studies. Then just a summary of the broader evidence, looking at some meta-analyses. Then the issue that I think is very relevant, point 4, TDM and antimicrobial resistance. Then a little bit about the actual clinical guidance. I think the implementation of TDM is challenging and requires a lot of work. And then just to maybe put it a little bit in the context of South Africa, where we are. So what is the clinical problem? Why does standard dosing reliably fail, especially in the critically ill setting? I don't think TDM is confined to critically ill, but that's where the highest use case is. There are other patients where it's of value. So, I think it really all boils down to what I said, the extreme interpatient variability and the pharmacokinetic chaos of critical illness. One of the things that has really come to the fore through our process of doing TDM over the last 3 years is our understanding of renal clearance in critical illness. Not only, so augmented renal clearance is a very real issue. is specifically in the subset of patients, young patients. So, and the single biggest predictor of augmented renal clearance is a patient who's 50 years or younger than 50. But yes, febrile neutropenia, trauma patients, burns patients, pregnant patients, these are all patients who often have augmented renal clearance. On the other side, those patients who have on paper normal renal function, but in fact have compromised renal function. This is a big shortfalling I've seen in the ICU setting, where unfortunately we don't have reliable markers of renal function. Using EGFRs in the critical setting is completely misleading. There is a trend, so a lot of people are using cystatin C, which is it's a cystatin molecule that's excreted by the kidneys, doesn't undergo extensive metabolism. So you can use that, but it is also not 100% accurate, and won't tell you exactly what the renal function is. So I mean, we don't really do proper assessments of renal function in terms of looking at urine creatinine clearance. So EM does highlight this, and we've seen this in many cases. Patients are put on what is considered normal doses based on their urea, creat, and calculated EGFR or whatever other calculation you may use. And in fact, they end up being on either underdosed or overdosed. We know about also expanded volume of distribution. This happens in septic patients, issues around hyperalbuminemia. I think another thing around and that relates to the protein binding changes as well, where you get increased free fraction and excess loss of drug, especially your highly protein bound drugs. The other thing where we've seen it is in your major surgical patients, patients with open abdomens, patients with drains, whether they be chest drains, so cardiothoracic units, big abdominal surgery. There's a lot of expanded volume of distribution and drug loss. ECMO is obviously another big area. And then obviously, as acute kidney injury and organ recovery, it's quite a dynamic situation. So we know patients who are overtly septic within the first, at onset, they might have a knock to the kidneys, but the kidney function improves quite rapidly. And sometimes these patients get placed, which, I mean, admittedly, they shouldn't be. If it's an acute kidney injury due to sepsis, one should use normal standard dose, reduced doses, but sometimes that does happen. And then unfortunately, patients remain on that reduced dose, and it doesn't get escalated in a timely manner. So these are really some of the core issues that lead to under and overdosing. What is the scale? So a few studies that highlight this. Obviously, the landmark study was 30 to 50%. That was the DALI study of patients beta-lactam therapy or underdosed, failed standard EKPD targets. Bearing in mind, standard was just percentage time above MIC, 1 times MIC. Some studies have shown actually for some drugs, about a quarter of patients have no detectable levels at a trough. And for the Swedish study, multi-center study, looking at some of the KIFR scores, 45% of patients fail 100% beat time above MIC in the first 72 hours, which, as you'll see, may be more critical, given that's when the bacterial burden is highest. Where do we stand? So if you look at our data, looking at beta-lactam levels, I've chosen the 3 most common beta-lactams that we would ordinarily use. And this is accumulated data I've chosen over a 14-month period. Also, this is data where from units that have been using TDM, but also units where dosing is very aggressive. And so these are not, this is based on what is considered today in South Africa accepted standard dosing. What I'm saying is when we use peptides, it's like 18 grams continuous or 4.5 QID extended infusion over 3 hours. Meropenem is 2 grams TDS extended infusion. Efabeam 6 grams or continuous 2 grams TDS extended infusion. So these are not, I say that as a standard. Obviously, some of the levels would be in just with patients, but that's sort of the framework within which we're working here. And if you focus, so just you've got peptides in blue, meropenem in orange, and cefepime in the gray block. So suboptimal incorporates toxic and below level, okay, in total. In other words, what we're talking about here is these are patients where we're not achieving a desired PK/PD target. I have a caveat is I have set the aggressive PK/PD targets here of 4 times MIC, 100% 4 times MIC, and we're considering these at trough level. And in fact, it would probably even be worse because from a practical level, many of these levels are not taken at the true trough. Just that from a practical point of view, getting true trough levels often means a second blood draw on the patient. So in the ICU setting, typically the bloods for TDM are done at the time that the routine bloods are done, which are early in the morning, and depending on is somewhere between 2 and probably 5 o'clock in the morning. And probably your true trough should be earliest 5:30, because most beta-lactams looking at the regimens would be, let's say, given at 6 o'clock. Obviously, it doesn't play a role. If you're doing continuous infusion, then you can take it at any time once you're at steady state. So you can see there, 60% of meropenem levels are suboptimal, 50% of cefepime, and around just over 35% of our peptide levels are suboptimal. What is also important to note is how many are toxic. Expectedly, cefepime, we know there's the highest toxicity threshold. Our threshold level for toxicity is the lowest of the 3 that I show you. Interestingly and optimal, we actually, despite a very aggressive dosing with meropenem, I know that's, like I say, in these units. I know here in this unit, you guys also use aggressive dosing. We're under 20% of achieving optimal target. And disaster, this is when I'm talking about you're not even above the MIC. So those disasters included in the suboptimal, but you can see a fair proportion of patients don't even achieve targets that are above the MIC that we of the target organisms. Some key studies, like I said, I've just chosen 3. There are many more. This study by Hansel in a Journal of Intensive Care Society, it was 2 ICUs, but a single city, Manchester. Small number of patients looking at peptides and meropenem. They didn't actually give the TDM results to the clinical teams. I think what was interesting here is this AMR finding that they found within this small cohort, is that 19% of patients carried a resistant pathogen despite standard treatment. And they made a note that subtherapeutic exposure selects for resistance. This is something that we'll come to again a bit later. I think the issue here is really just about timing of TDM and making sure they are reliably available within time, so that you can adjust dosing within a reasonable time frame, given the variabilities of pharmacokinetics within the individual patient in an ICU setting. What you see now versus what you see this evening at 6 o'clock may not be the same situation. So we need to make sure that that we have that critical gap of laboratory coverage with real-time TDM. The second study, this was also interesting and maybe is leading towards a shift, because in our initial work on this, was about looking at TDM at steady state, which means waiting a period of time before you actually do TDM. This study by Alshia et al. Looked at the impact of TDM timing. And if you look at the key finding there, that the delay in TDM sampling was independently associated with clinical failure and higher 30-day mortality. This was a larger study, almost 300 episodes of TDM. They looked at clinical cure and 30-day mortality. Interestingly, their most common organism was Pseudomonas, and most common drug, ephedrine, used as an intermittent infusion in most cases, not as a continuous infusion. So that may also have played some role. But you can see they actually saying, and it's sort of with beta-lactams, I think it is attainable that one would want to do TDM earlier rather than later to make sure that you're achieving that target within the most critical window, which is when the patient is overtly septic. I think there are, I don't think, I mean, it's TDM is always better late than never. So day 3 is better than none, but may not necessarily be optimal. But I still think it's worth doing, even if you miss that time frame when we look at it from the resistance perspective. So, I mean, in this cohort, median time from antibiotic start to first TDM sample was within 3 days, 2.7 days. And this is a sort of systematic review looking at all the factors that drive PK variability in ICU. I put this in because I think it highlights and endorses the 2020 position statement guideline that was put out about the use of TDM in critically ill patients, where they recommended for those particular drugs listed there, your glycopeptides, aminoglycosides, beta-lactams, linezolid, and voriconazole. What you can see on the right in the table are the various pharmacokinetic factors and where the priority for TDM actually lies. So any impact on renal function, I think any patient on renal replacement therapy in an ICU should be on TDM. I think all these guides, the package inserts, lexicon, MIMS, I don't know, whatever, Sanford, whatever you want to look at, it's all a thumbs up. When the GFR is less than 30, then you do this. The reality is we don't know what the GFR is. We don't. So how can you make that? How can we actually use that information to reliably guide dosing? And then, yeah, as you can see, ECMO, hypoalbuminemia, organ recovery. So this is very specific to the pharmacokinetic variables. There are obviously other variables that we would advocate for use of TDM, but we'll get to that. The broader evidence. So just looking in general, and I think this for me is a very important slide. If you look at a recent systematic review that was done, and this has been supported by a few others. If you look at clinical cure, microbiological cure, treatment failure, and target attainment, these are the 4 variables that are shown to be improved with use of TDM. So clinical cure, if you look at that relative risk ratio, we talk about a 17% improvement. Microbiological cure, we talk about a 14% improvement. Treatment failure is a 21% reduction in treatment failure. And target attainment obviously makes sense. You almost double, 85% improvement in target attainment. Okay. What has not yet been shown is the issue of all-cause mortality and length of stay. And this is the what do you want to call them? The naysayers will say, oh, it hasn't shown a mortality benefit. How can we use it? Blah, blah, blah. Which is very interesting. So, number one, it's interesting in the fact that is mortality really the right variable we should be looking at? When you're looking at a critically ill population and mortality as an endpoint in terms of an intervention within a 30-day window, there are just so many variables that this small variable, it probably does play a role, but designing a study to show that would be, I think, is going to be impossible. just too many things. So I think a lot of the issue around mortality signal is around trial design limitations. Also, the way the trials are done, sampling, the pre-analytical is taken into account. Also, we're not always, the studies they look in general about TDM, they don't look at pathogen related. What is the MIC? Many times the microbiological determination of susceptibility is not well explained. You have a very heterogeneous population. Again, this is the issue about in ICU, such variable characteristics. Patients die in ICU for many reasons other than not achieving a TDM level. So I think these trials are underpowered to detect mortality. And my biggest thing is I don't think mortality is really the right endpoint that we should be looking at. We need to be looking at these particular aspects: microbiological cure, clinical cure, treatment failure, PKPD target attainment. The other thing that actually came up over the weekend, I attended a conference which was also the same question around TDM and its lack of mortality benefit. If we think about many of the other things we do in an ICU setting and we are dogmatic about doing them, yet they have never been demonstrated to have any mortality benefit. So a good example on the laboratory front is PCTs. Doing a PCT and stopping your antibiotic and the X level or deciding to escalate, or it has not ever been shown to do any mortality benefit. Similarly, we're searching for mortality benefits on this, yet we will happily use various concoctions and antimicrobial combinations based on purely observational evidence that is, quite frankly, poor. It's not even, never mind randomized controlled trial, it's not even close to being at a high level observational quality data. So I think I'm not in favor of this thing of saying, well, we cannot use it because there's no mortality benefit. Okay. So I'm not going to go into why the RCTs are negative. I think I've discussed that. There's many reasons, but yeah, you can go through some of these issues. Then there's the other issue around therapeutic drug monitoring and antimicrobial resistance suppression. And I think this is a very overlooked clinical imperative, especially in our context. Our context, there in the table on the left, or the bar graph, bar/line graph, which shows you CRE and ESBL rates for Klebsiella pneumonia bloodstream isolates over a period January 2019 to June 2025. And if you had to draw a straight line from the far left dot to the far right dot, you will see a very slow upward trend. And that's what we've experienced. The green is your ESBL rate. So percentage ESBL, as you can see, it's above 70%. It hovers between 2/3 to 3/4, 66 to 75%. And interestingly, our CRE rate is 52%. These are isolates from the private sector. If you look at the public sector data, it's not that much better. It just shows a similar upward trajectory. The overall rate is slightly lower. Whether that's the rate is truly low or not may be an artifact of how testing is conducted in NHLS. But it's immaterial. Their rates are still well above 10%. Depending on where you look at 40% plus. So it's, we sit with a very significant CRE as well as ESBL problem. So, and when we talk CRE, ESBL, we're talking about beta-lactam therapy. These are core resistance mechanisms to beta-lactams. So what is the data about this show in terms of TDM? Well, before we get to that, one must just look a little bit about the biology of resistance emergence. So really you have kind of windows of concentration level. So your sub-MIC zone is where you're less than 1 times the MIC. That's what I call the kind of disaster zone. you will have insufficient bacterial killing. If you have a high inoculum, it will just persist and overgrow, and pre-existing mutants survive quite clearly. Your mutant selection window, which is 1 to 4 times the MIC. So this is as a minimum where we would hope to be if in terms of concentration level, where you kill off the wild type, but resistant mutants may well be amplified, especially with poor source control type infections. And then we get to our resistance suppression zone, which is the 4 times the MIC and greater level. And this is where you can actually suppress your resistant mutant selection. So it has both an efficacy and a resistance prevention target for TDM-guided dosing. And that's why I said our targets are aggressive, because we would aim for that. I think that's, for me, is the right place to be. In terms of our efficacy target, as we know, with beta-lactams, it's 100% free time above the MIC. But if you're looking across the board at various drugs, then obviously concentration dependent, we want our Cmin to be above the MIC. Sorry, not this. That's not concentration. That's for a continuous infusion as your trough. You want your concentration to be 4 times the MIC. And you want to maintain that for 100% free time above MIC. And in some aspects, an area under curve to MIC ratio is also important. So these are the kind of targets that we would really be aiming for to suppress resistance. In terms of the literature, so this is a recent, also a fairly recent study that was published last year. It was of particular interest to me as it was conducted in transplant patients. So solid organ transplant patients in Italy. They looked at continuous infusion beta-lactams combined with TDM. And really, I think on the right, you can see the spectrum of organisms. They see a lot of what we see. There's OXA48s, there's KBCs there, there's MC, ESBL, carbapenem resistant, acinitas, multi-drug resistant, Pseudomonas. So they've got a nice spectrum of resistant organisms. And in the study, they basically were looking at what is the impact of not achieving your aggressive PKPD targets on development of resistance and suppression of resistance. And as you can see, the only independent predictor of 30-day resistance, so following these patients up for 30 days, regardless of the organism, infection site, or combination therapy, whether you used combination or not, the only independent predictor was suboptimal or quasi-optimal PKPD target attainment. So again, this supports the fact that if we do not achieve these targets, we're actually contributing to the problem of resistance down the line, especially. This is supported by a number of other studies. I don't know if I need to go through all of these. The one that's of particular interest to me is the third one, the Conjuti study, which is conducted in febrile neutropenia, oncohematology, where we know antibiotic use is often appalling. Patients are on broad spectrum from the get-go and remain on for long periods. And the biggest issue here is, like I said earlier, febrile neutropenic patients are the ones most likely to have ARC. They're often young, often have kidneys that are just fine, and they get dosed, which what you think might be aggressive dosing, but they're woefully underdosed. We've seen a number of cases where the meropenem levels are in the boots, and you can be on 3 grams QID and you're still not achieving levels. And this study actually showed that 0 patients developed CRE colonization within 3 months following proper TDM-guided continuous meropenem. This is always an issue. You read in the literature a lot about continuous meropenem, yet we have this issue around stability, and I don't know if it's just a formulation thing. It might be worth looking at, because I think continuous meropenem would be a valuable addition to the intermittent infusion. We found if you you can increase, QID even 4 hourly, then you can really start attaining levels. So I think the value of the continuous infusion would be good. But again, it's another discussion. So I really think that TDM-guided resistance suppression is an important thing that we need to be thinking about. In terms of some of the clinical guidance framework, when to use TDM, to sample, what targets to aim for. So you've seen some of these already. What are the indications? Like I said, there are many other pharmacokinetic variables that are mandatory indications. Then there are a few others. I think the MDR, or difficult to treat organisms, especially MICs and you've got a target. This is where I see the utility of TDM outside of ICU patients. We've used it, like in patients with prosthetic devices. We're going to need long-term therapies where there's issues around toxicity, the types of infections, central nervous system infections, endocarditis. There's many. You can extend this list depending on what you think is important or not, but I think these are some of the most important places and evidence-supported indications. What are the targets? Again, not a fully comprehensive list. Unfortunately, for some of the drugs, targets are very poorly established, especially toxicity targets. I think the efficacy target and resistance suppression target is not too difficult to ascertain, because if you know what a clinical breakpoint is and you can multiply that by 4 for the beta-lactams, then you know where you should be targeting. I think quite a lot of work has been done on linezolid, so those targets are supported. And as is the case with voriconazole. But you'll see, so for example, ertapenem is one that stands out. We all consider ertapenem quite a strong neurotoxic carbapenem, yet the actual level associated with ertapenem neurotoxicity is very poorly defined. And in fact, again, I think it boils down to the interpatient variability. What's toxic for one may well not be toxic for another. We've seen patients like the ceftazidime, say maybe around 80, and most patients tolerate ceftazidime very well, but there's one particular patient that I'm aware of who the patient had to have ceftazidime repeatedly for transplantation, recurrent infections, but the patient was highly susceptible to toxicity. Even once you start getting a level of close to a target, which is 32, started to went a bit haywire. So we started to look outside of the beta-lactam group of antibiotics. And the one issue, cefepime, a lot of the literature supports that, between 20, if you're getting closer to 30, you're already in the toxic range, which is a bit of a difficult thing because our target would be 32, actually 4 times the MIC. Again, it's variable. We've seen patients who are quite comfortable at that in the 30s range. No signs of toxicity at all. Again, there's a lot of interpatient variability. The South African context. So I think I've already shown you the issue of 30 to 50% carbapenem resistance in South African, just Klebsiella pneumonia. We know we see it in many of the other organisms, E. coli, serratias, enterobacters. It's a substantial problem that we deal with. And it's only got worse in the last decade. Since we first started seeing CREs in 2011, our CRE rates have only got worse. One has to ask why. But conjecture, there are plausible reasons. Also thinking just about some of the context, we may well have much higher augmented renal clearance rates in a younger population. Obviously, depending on the community you serve, but there is a substantial number of patients with augmented renal clearance. If we look at our HIV-TB comorbidity and the influence of co-administration of other drugs that influence metabolism and drug binding. Yes, our NDR escape pathogen burden. Remember, it's not only in some pockets Pseudomonas aeruginosa. And we know Pseudomonas already on our breakpoints, we know that we should be using high dose to treat all serious Pseudomonas infections. Because the breakpoints are premised on the fact that we use higher doses. Standard dosing for Pseudomonas is a non-entity. One shouldn't be using standard dosing. We also know that carbapenem resistant and multi-drug resistant Acinetobacter baumannii in some places is a very substantial problem. So yeah, I think there's a lot of opportunity here in our setting to maybe lead TDM implementation, looking at its value in the South African context, and to actually generate some data within Africa. Because at the moment there's just no data in Africa about TDM. So a kind of three-tier precision dosing approach. So I like the thing precision dosing. I mean, we all know about sort of where medicine's going, precision medicine, and why should we not be using antibiotics in a similar way? It's not the one size fits all. And again, remember, I'm referring to specific patient populations. We don't need in outpatient settings. This is not really necessary. Provided that good dosing principles are used. But we talk about, I think, as a start in our ICU patients, where routine TDM should become part of our thinking. It's not for every patient. Again, I don't see many patients are on antibiotics in ICU, but they're on, it's for very, let's say, what's the word? Fluffy reasons that they're on antibiotics. So within 2-3 days, they're not going to be on an antibiotic. No point in doing a TDM there. Although having said that, suboptimal exposure does impact on resistance, but I wouldn't advocate for TDM in those kinds of patients. But patients with serious infections who you're treating with antibiotics, we have issues. Whether they be pharmacokinetic, whether it be related to interventions like ECMO, renal replacement, whether it be because of the organism that you're treating as CRE. I think these are the kind of patients where TDM should be used. And we should be aiming for the 100% free time above the MIC, or 4 times the MIC. And yes, also thinking about, are we suppressing resistance? Are we meeting those targets that are above the threshold that would suppress resistance? This is important. And then down the line, what the future may hold is what you should actually, where places like in Germany and some of the European nations, Netherlands, where they've been doing this for quite a while, is where they do model-informed precision dosing. So what's quite nice, it's not that you don't use TDM, you still use it, but you create models based on your patient population so that you know from the outset what dose to start on. You can actually reliably then start a patient on, 4 grams meropenem QID, for example, because you know from your model, this patient meets criteria X, Y, Z, they are most likely going to be underdosed with our standard 2 grams TDS. We start them on that. You then do a level down the line, and maybe you adjust. Maybe you see, okay, no, I'm fine. But that requires building up of data. It's also unit specific. You need to know your patient population, so it's not going to be the same year as it would be like in Don Gordon, where there's a lot of transplant patients. The transplant patients would be a unique population where you'd have to develop a separate model. a unit, a level 1 trauma center would have to have its own model for trauma patients. So it's actually not just units, it's also patient dependent, the type of profile that you see. So that would be a nice place to be ultimately. So the 5 pillars for routine TDM in critical care. I think number 1, we know exposure failure is common, cannot be predicted. We've known this for 10 years. Actually, no, it's 11. 2014 was Jason Roberts' DALI study. Apparently there's a DALI 2. I don't know why they're doing it, because then nothing's changed. Well, maybe in some places where they're doing TDM routinely, yes, but it's still our only way to really know what's going on. It does improve infection-specific outcomes. Clinical cure, microbiological cure, reduces treatment failure, obviously improves our target attainment. Earlier TDM is better. I think timing is important. We need to look at that, make sure we're doing it within the right time frame. And then in our setting, the issue of resistance emergence and the fact that TDM can actually suppress resistance emergence is a very, very important. And as you've seen, there's quite a bit of literature supporting this. And then lastly, drug toxicity. We underestimate, beta-lactams, they're very safe antibiotics, but we've seen now, and you see clinically, obviously, many patients they're on what we think are appropriate levels of toxicity. And one can avoid this toxicity by adjusting your dose in a more timely manner. So that's it. Thank you. I'm happy to take any questions.
Thank you so much. Thank you. We appreciate really the presentation. I mean, quite a lot of insight into TDM. I mean, we don't do that more frequent. I think we just meropenem currently. But the questions that because we haven't extended into imipenem, you guys did say imipenem because we have a current patient that develops syncope. That was the question whether she actually have, because of this from the imipenem, because we know that imipenem and azafenib was do calculate that actually give you seizures. And I mean, you always treated very well on your presentation about a toxic level of imipenem is less than 20 ng. So the question that should we be testing for imipenem and when exactly?
So the principles for imipenem are same as meropenem in terms of your PKPD target, the timing. We don't have a lot of data on IMI because it's not the most commonly used carbapenem, and we haven't done a lot of frequent TDM on it. What is interesting in the ones that we have done is actually getting levels up high or challenging. I think the issue of imipenem being a combination drug with a simvastatin, its metabolism in the kidneys actually leads to subtherapeutic levels from what I've seen. Even with you go 1 gram QID. I actually think imipenem we should be using much higher doses. I think the underexposure issue is probably more problematic than overexposure, but yes, I mean there will be patients where they are overexposed, and yes, imipenem we know in terms of the ranking is a more neurotoxic carbapenem than meropenem. I do. We can do it. We can do it for all the carbapenems. Obviously, I have the most data from meropenem. I have fairly limited experience with the imipenem, just like I said, based on the use of TDM. But yes, I think whatever carbapenem you're using, I think it's important in the right setting, like I said, to be using TDM. Yeah.
And then I think just follow-up question regarding the role of albumin in critical care. I mean, we obviously know that once you're in critical care, the albumin is quite low. And I think there are quite a few drugs that actually bind to albumin, obviously, and that obviously will affect your TDM.
Yes.
And I think we also know that there are quite a lot of multiple studies that actually say that the albumin actually that's not replacing it. That's change in mortality. So the question, I mean, you do also alluded to the fact that mortality is not what we should be looking for, because I think we keep focusing on mortality, but we should actually be looking at about the length of stay. We should be looking more about the outcome improvement all about. Will you comment a bit quickly about the albumin? Do you think we should be, for those antibiotic drugs combined to albumin, within the role of that? And how does that affect your TDM monitoring like care?
It does affect your, I think it affects your exposure level. And I'm always wary in hyperalbuminemic states about using drugs that are highly protein bound. Like you said, I'm not 100% convinced that supplementing albumin is going to help with a drug exposure. So in those patients, I would rather do the TDM. But actually, as a first port of call, I would look for alternative agents. This is, so my classic example here, and unfortunately we don't do it as yet, but it's on our development pipeline, is to do TDM for the highly protein bound daptomycin. The one we can do it for is ertapenem, which is highly protein bound. But I think those, it's interesting, those are the very drugs, like if you look at your staff, MSSA, the standard of treatment, which is so-called cloxamifene, that are highly protein bound. We give them in critically ill patients. We have no clue about the drug exposure of those patients, and it is probably suboptimal. And this may well be a reason, because this is my only conjecture and I'm speculating, but may well be the reason why staph infections do so poorly and we have this relapse down the line, because we're using drugs that the exposure is just poor. So sure, you get a response. I think that's also the thing, just to make this comment. People think, oh, it doesn't matter, I get a response. Yes, you get a response, because you don't know if the MRC, if you're treating an ESBL klebs with meropenem, do you know what the normal MRC is going to be? Somewhere between 0.12 to wild type 0.12 to 0.03 or something. 0.03, imagine that's the MRC. You only need like concentrations of like 1 in the serum to suppress resistance even. So yes, you're giving 500 TDS. It's a dismal dose, but for the pathogen and maybe the urine tract infection, your levels are way above the 0.03 MIC. So yes, obviously you're going to get a response. And again, that comes to the issue around the design of these studies that look at TDM in terms of outcomes and how they choose the outcomes. So you're never going to see a mortality benefit in that patient. It is no. So there are patients who are going to do well irrespective. The question is, yes, you raise the point, like, what about the smaller things? Like, does the length of stay in ICU reduce by 1 day? That's quite a big impact from a financial resource perspective, from an overall outcome perspective. Do you reduce the chance of that patient when they get admitted 3 months down the line being colonized with CRE? That has an impact. The clinical response, the clinical response, like we saw, your microbiological response, these are all improved. So these are small things that, if you add them all together, they have a significant impact on the overall health outcome of the patient.
Got 2 questions. The first one is, we do a lot of clinical sectors, Avibactam patients with decreased renal function, because I find that it's quite a tricky infection because it's so resistant, yet the patient is mostly compromised. So when they are on continuous renal replacement therapy, it is a bit easier, but when you go into H2, that's where I think I struggle to get that balance between efficacy and toxicity. And my other question is, we can measure the cephas IV component of the estrogen
Yeah.
can't measure that yet. So
Heavy bacterium, always true.
yes, so what's
That's
your
on my wish.
experience of that, and what would you recommend in a patient?
So what was your first question?
So
In the
patient
HT, you must just do this must be purely TDM guided.
Okay, but so it's sufficient to just to do the symptoms.
So the avibactam, remember, with your beta-lactam concentrations, you actually just want to maintain above a threshold. So the avibactam reported threshold is 1. We can't test the avibactam at this point. Maybe the PIPTAS literature suggests that you should look at the beta-lactamase inhibitor component because they specify. I don't know if you saw, there was a thing there, quasi-optimal versus suboptimal. The quasi-optimal in those cases where the piperacillin level was fine, but the tazobactam wasn't. And the final ratio there, we basically wanted above 4. We target for tazobactam 6, as long as this, you need it above 4. They talk about a concentration threshold. For the avibactam, it's 1. Whether you won't get 1 is, I don't know, it's quite, it's something we'd have to look at. But with what we currently have available, yes, I think the ceftazidime is the most important component, number 1. The avibactam is, whether we can get that tested or not. I would like to add it on to our pipeline. And then we will have dedicated concentrations defined above the threshold. But I mean, in those patients if they're on dialysis, I would just make sure that you are following them up with ceftazidime levels to know where you're at. For the aztreonine, that's in the pipeline. But the reason we're doing that is because of the possibility of aztreonine avibactam coming. Not for the ceftaz AV plus aztreonine combination, because I don't think that's necessary.
And then my other question is, sometimes we forget about the toxicity factors. So I think most of us feel like ranitidine is quite a safe drug, which I think we are a bit delusional.
You are very and you are so right. And what has been also, this has been also an eye-opener for me doing this, is the number of patients on linezolid who are toxic in ICU. Because the problem with linezolid is in their phase 1 pharmacology studies, all they did was, obviously they use healthy. If you look at the package insert and all the dosing recommendations is no dose adjustment for renal dysfunction. So everyone has been getting 600 BD. That's the standard dose. Yet you have a drug that is 30% of that drug is renally eliminated. So you'll be quite surprised to see how many patients in ICU on the standard 600 BD have levels in the 20s. Now, it probably doesn't make that much of a difference in those patients. That's why it hasn't flagged as such an issue, because the duration of therapy with a linezolid is probably not long enough to create a problem. I don't know, there might be some, we can't say for sure, there might be some issues that does create problems for patients, so that's not something. But we know it's with a longer term therapy that when you're in the toxic range, you start to see serious side effects. But I'm definitely, I think the 600 BD as a standard dose for linezolid for every patient is incorrect. If you look at levels, it's actually just incorrect. And in a way, it makes sense. I mean, the drug is, a third of the drug is really eliminated. So it's not that unsurprising. Just on back to the point about the albumin, hyperalbuminemia, that's another thing that we also have to factor in, and it's on our side in terms of reporting, because I don't think we adequately look. Like I said, we don't do enough of the drugs that are highly protein bound, so it's not such an issue, but we should give you some indication of what do you when you should be adjusting the space because it's a highly protein bound drug. What is that level actually? Kind of thing. I must admit, I get it with hyperalbuminemia. Also, it's not a hyperalbuminemia by definition. For me, it only becomes an issue when you're starting to get 20 and below. That's the very low levels. That's an issue. We don't, when you it's like 28, you just below 50. I don't think this is such a big problem.
I think as is okay.
Not long ago, we had an elderly lady, and we were treating her with a second beam infusion. And then because her renal function was also due for as low, we decided to check the level, and it came back as low, despite 6 grams over 24 hours.
Okay.
So, in a patient like that, why would it come back as low? What's the most likely reason for it to be? Is it the volume of distribution or what?
How old was the patient?
Like late 70s.
Okay.
80s, yeah.
And you say why was the you did the level because you thought the renal function was actually compromised?
Well, because I had a patient who was on peritoneal dialysis not long before that who got neurotoxicity from severe. So I was like, I don't know.
Oh, okay. So there was nothing. Okay, but there was but there was nothing in the paper that made you particularly.
No, he had a bit of dementia. And she was already a
Oh, Greeks. That's fair enough. And I think so the 70-year-old. Remember again my point. You don't actually know what the renal
the discussion.
Oh.
How much?
So stay stop.
Yeah.